Hello, my name is Victor Guillen. I'm a PGY2 resident of internal medicine at Mount Sinai Medical Center, Miami Beach, Florida, and I'm here to present this atypical case of Lemierre syndrome in a patient with an intra-abdominal abscess and bacteremia due Fusobacterium and Clostridium rhamosomum. As an introduction, Lemierre syndrome is an uncommon complication involving bacterial invasion, often from Fusobacterium species, into the oropharynx and its surrounding vasculature, resulting in a septic thrombophlebitis of the internal jugular vein. It is often associated with anaerobic septicemia and then the development of the distant septic emboli. Abdominal variants of Lemierre has been reported involving thrombophlebitis of the portal and mesenteric vein, also known as pieliphlebitis, that is a rare condition occurring in low frequencies. The case presentation is about a 59-year-old male who presented with 7 days of worsening abdominal pain and 3 days of vomiting and diarrhea. No other symptoms report. History relevant for 35-year history of smoking and drinking 1 bottle of vodka every weekend. Initial assessment displays mild abdominal distension and tenderness and palpation in the epigastric and right iliac area. Also, the patient had scleral icterus. Vital signs all were unremarkable, and labs revealed neutrophilic lymphocytosis, thrombocytopenia, transaminitis, hyperbilirubinemia, and elevated alkaline phosphatase. Blood cultures were positive for Fusobacterium and Clostridium rhamosomum. Abdominal CT and MRI of the abdomen were consistent with distal biliary duct stricture, superior mesenteric vein thrombosis, and chronic appendicitis. Treatment involved a biliary stent placement via ERCP, anticoagulation with heparin, and antibiotic therapy with piperacillin tazobactam. After treatment, the patient showed clinical improvement with improved laboratory values and negative blood cultures. A repeat abdominal CT, however, showed a new finding of pancreatitis as complication of the ERCP. With this complete presentation, the patient's chronic appendicitis was deemed unsuitable for surgical intervention and was managed medically. Given his Fusobacterium bacteremia and the SMBV thrombus, the diagnosis of abdominal variant of Lemierre syndrome was made, necessitating evaluation for a distant emboli risk. A CT chest provided afterward showed an incidental finding of descending thoracic aortic aneurysm with penetrating arteriosclerotic ulcer. By the day 16 on the hospital, the patient continued with antibiotic and anticoagulation therapy. The patient's clinical conditions improved significantly, aligning with the normalized laboratory values and slightly improved in the radiographical findings. Discharge instructions include oral ampicillin sulbactam for 2 weeks and anticoagulation with rivaroxaban therapy for 3 months. He was advised to follow up with surgeons for the chronic appendicitis and TCBS for radiographical aortic findings. In discussion, this case presents a rare abdominal variant of Lemierre syndrome, deviation demanding prompt initiation of anticoagulation and antibiotic therapies for an effective management. Further, this case is a first to report an SMV thrombus with concurrent aortic aneurysm and PAUs. This underscores the need for comprehensive assessment to address distant emboli risk and possible unconventional ramifications of bacteremia. This patient development of post-ERCP pancreatitis serves as a reminder of the procedure's most common complication and the importance of preemptive measures like NSAIDs suppositories to mitigate pancreatitis risk. Finally, chronic appendicitis, a rare and milder form of appendiceal inflammation, added complexity to the management of this case. While typically managed surgically, this case serves an example of medical management when surgery is not an option.